All right, take it away. Thank you.
I'm with Amit, and I think the NFL is the new underpants. Though I'm really a bigger fan of soccer and professional cycling. And I think it will be interesting with healthcare if I think like drug testing will be a major feature in a lot of those predictions. But thank you very much for giving me this opportunity to talk about the work that a bunch of my data science teams are doing at Castlight in the area of healthcare. And I'm going to talk about a couple different areas, but I have to set some background. I think healthcare is a really complicated thing, a mildly controversial topic in the United States, and also a very expensive thing. So healthcare right now is about 18% of the GDP in the US. And it is growing, albeit in the last couple of years, somewhat correlated with the introduction of the ACA. Those costs are not growing quite as fast, but still going up. And it turns out that over 50% of the population receives their healthcare coverage through an employer. And they're faced with some pretty staggering expenses that are growing. For a lot of employers, a pretty high percentage of their expenses actually go towards the healthcare for their employees. I think there was a famous quote a couple years ago from a GM, I don't know if it was the CEO, said that there's more cost for healthcare for employees, for them, than for the steel that goes into cars. That may just mean there's a lot more plastic in cars, but I think it is pretty expensive. So employers are facing a lot of problems right now. And so one of them is just say that like when companies are small, they're what's called fully insured. And so up to about 1,000 employees will be fully insured. And they're paying premiums to an insurance company to, first of all, they set up a provider network, then negotiate reimbursement rates with providers. They then adjudicate the claims, and then the insurance companies pay out the claims. And they try and set the premiums high enough that they can pay out those claims. But once you get over about 1,000 employees, most employers will become self-insured. And when you're self-insured, the company, the employer is actually really the insurance company. And so even though the health plan or insurance carrier, payer, a lot of different names for these companies, and I'm talking about companies like Anthem, Aetna, Cigna, UHC, while they still adjudicate the claims and they pay the providers, that money is actually coming from the employer as well as from you, from the employee. But the employer is paying most of that cost. And they don't really have a lot of options to control that expense. So employers need to offer good healthcare benefits to their employees, otherwise they will struggle to compete for top talent. And so there's a couple different strategies that have been used. So copays and premiums actually haven't been going up that much recently. It's really more into deductibles. So employers are shifting more of the cost to their employee by these higher deductibles. So about 50% of the employers in the US offer a high deductible plan to their employees, and about 30% of employees are actually on one of these plans. And for an individual deductible, that means roughly about $1,400 to $1,500 a year. It's kind of the minimum to be called a high deductible plan. The other thing that they're doing is what are called narrow networks. So again, the insurance companies construct these networks of providers that are in network that there's a negotiated rate. And so it's known what the cost will be. Exactly what that cost will be is part of the problem that I'll talk about. But when you go out of network, all bets are off, and the provider can charge whatever they want. And so you generally want to always go to an in-network provider. What's happening a lot is these narrow networks are becoming narrower, in some cases very narrow, and there will be tiers of these networks. And in that, when it's done well, it will limit choice to high-value providers while squeezing out the lower-value providers, but only when it's done well. And the other thing that a lot of employers tell us is they offer a lot of related healthcare benefits, like disease management programs, wellness programs, maternity programs, but the utilization of those tends to be under 5% of the population, and many of these, they are suitable for much greater percentage of the population. But the best way the employers can tell their employees about it generally is just they talk about it at open enrollment, which I know UC is going through right now. And so you hear about all these benefit programs right now, but then months later, when they actually possibly become relevant to you, you've forgotten about it, and then you never sign up for it. And so they don't have a really good way to communicate with their employees about these benefits. So employees also face a lot of challenges as well. So because, of course, the increase of this cost share for their high deductible plans that many of them are on, that has a big impact on their finances. And then, to make that even worse, you generally only know the price after the service is rendered, which is pretty nuts. You know, I do like Tesla cars, but I would not buy one without knowing what the price is. But yet we go to the doctor and have no idea what the price is in general until we get the bill. There's not a lot of situations like that. And then, in addition to that, the out-of-pocket pricing is very complicated. So you have the individual deductible, the family deductible, there's an in-network deductible, out-of-network deductible, there's co-insurance phase, and there's tiered provider networks that may actually have different deductibles. And then with pharmacy pricing or prescription drug pricing, you have a pretty similar structure. And so even if you got to your doctor or their office and you asked them how much a procedure was going to cost, first of all, they would have to know what plan you're on, and so the price could vary depending on the plan you're on. But and it's pretty unlikely they're going to be able to tell you that price. But even more so, they're not going to know where you are in a deductible, the provisions of your plan. They won't be able to tell you the out-of-pocket price. And for most people, that's what they really care about. They want to know how much am I going to pay for these procedures. And then there is a lot of quality data that's out there. There are a lot of different sites, CMS, Center for Medicare and Medicaid Services, Leapfrog Group, the Joint Commission. A lot of regional coalitions have this quality data, but it's hard to pull it together. And it's very rarely is that quality data available along with cost, which is what you want to know. And then, again, just like with employers kind of struggling about communicating benefits, employees typically only find out about their benefits during open enrollment. Even though I work at Castlight, if you ask me to tell you all the benefits, healthcare benefits that Castlight offers, I'm pretty confident I would not get them all. So what we offer is a health benefits platform that helps our customers' employees and their families make better healthcare decisions. And a couple different ways. The two big ways are finding better care and by cost, quality, and convenience, and having all that information in one place. And also, we help them understand and optimize their healthcare benefits. So our platform is available to over 200 employers. Some of the I think it's about maybe 55 of the Fortune 500, so very large companies. So we do sell to large self-insured employers. And I'm very pleased to say that in January, Castlight will be available to University of California employees. And I'm sure all the UC employees, you've read the open enrollment pamphlet cover to cover. And so you already knew this. You knew this was coming. I didn't have to tell you that. And as it turns out, my wife runs the radio station at UC Berkeley, CalX. And so she will become a registered user. And so there's just a little bit of pressure on me to get everything right starting in January, more so than in the past. So this is just going to show one screenshot from the application. This is from our demo system. And so the user is logged in, and you can search for doctors by name, by specialty, condition, procedure, a lot of different things you can search for. And in here, I'm just searching for adult primary care and showing providers that are in-network and the out-of-pocket pricing for those providers. And this is a demo system, so it's not real providers and prices, but this is actually pretty realistic of what you would get if you did a search. And you can see up there in the top right, like the price range, $40 to $307. That's not that unusual. Typically, like in office visits in a small area, we'd see like 3 to 4x across the US. That's pretty normal. For lab test imaging, 8 to 10x variance in pricing. So there can be huge variance in pricing, and not really well known. And then you can drill down on these providers, get more information, see patient ratings of these providers, and so other quality data. Mostly with the quality data that we have is about facilities more than practitioners, just because it's not there, other than for surgeons. So in our data set, when we launch an employer, it comes onto Castlight, we get about 2 years of historical claims data. And so right now we have over 1 billion claims in our database. So it is a pretty big data set. And then basically every day we get more claims. And so we get incremental ongoing claims into our system. So what we're doing is we're building, and so some of the things I'll talk about, machine learning algorithms that we're using to predict the prices. And we're reverse engineering these negotiated rates between the insurance companies and the medical providers in order to do this. And so this ongoing data gives us nice test data as we go forward to continue to test the accuracy of the prices that we're predicting with new data. So it's very important to have that constant new source coming in. So we consolidate a lot of quality data, And again, from those sources, from the government and from a lot of third parties. We will also license reviews from Angie's List and a couple other providers, as well as the reviews that are done by Castlight users of providers. And then all the things that people search on, the content they look at, how they interact with recommendations. We then use that data to be able to provide better recommendations. In the second part of the talk, I'll talk about how we use machine learning to make personalized recommendations. So now for the price prediction part. So why do prices vary? And they do vary a lot. So there are a couple of factors that you can use to somewhat predict, at least at a high level, what prices are likely to be. And one of the main ones, probably the biggest one that we normally see, is the negotiating power of large medical groups. And there have been a couple of recent articles about some of the dominant providers in the Bay Area, and they have a lot of sway, a lot of control over with the price because they have such a large market share. And that actually is probably the biggest driver of what the price will be. So providers, partly for efficiency reasons, they will negotiate in groups with insurance companies to determine reimbursement rates. So it's efficient because they don't have to do all that work themselves. But also, if they can get together a big enough group, then they have this market power. Supply and demand is a big factor as well. So when you have specialists, particularly like in rural areas, the insurance company will want to have a certain number of those specialists in the network so that the plan will appeal to employers. And so those specialists know that. And so that gives them power in these negotiations. And then some of the prices, the reimbursement rates, they will reflect operating costs in different geographies. So the Bay Area and like New York, unsurprisingly, the reimbursement rates are higher. So there's something that's missing. And what's missing here, I think, is the little image. Oh, there it is. Quality. So you think, like, why didn't I mention that? Why isn't quality a big factor in these reimbursement rates and the cost for healthcare? So sadly, it turns out that cost and quality in US healthcare is not correlated. It's correlated in a very strange way. So if it were correlated in the way you might think, so in a normal market, you would think for products and services that low cost, low quality, high cost, high quality. There would be this line would actually be from the bottom left to the top right. And instead, that's not what we see at all. So this data is about a little over 10 years old. But trust me, none of this has changed in the analysis that we do. It still looks like this. And it's because it's an opaque, non-transparent market is a big factor in why this happens. So if I haven't already convinced you, or if you weren't convinced coming in, like why transparency is important, there's a couple more reasons. So when people don't know the cost of something, especially something like healthcare, they won't spend for it. And so they will neglect needed care and won't go to the doctor until the problem gets worse. And then eventually it has to be treated, and then the cost can be much, much worse than if through preventive care it had been addressed up front. And then we all end up paying for that. Also, when people don't know where to go, they're concerned about the cost, they will, in many cases, use the emergency room for a lot of their primary care. And it takes a long time, incredibly long waits, and it's very, very expensive, and it's very costly to everyone when people do that. And it is actually quite common. We see a lot of avoidable uses of the emergency room. It would be better for everyone if those people went to urgent care. Not always, but there are a lot of cases, more than you might think. And then also, it would hopefully reduce the unjustifiably wide variance and just the overall level of pricing in healthcare if it were a more open, transparent market. So this sounds like unicorns and rainbows. Transparency does. So like, why not? Why hasn't this already happened? Why isn't it like really broadly out there? So there are business reasons for that, as often is the case. So for the insurance companies, they're in a highly regulated business. They don't have a lot of ways to compete with each other. But one of the ways is through the negotiations that they do with these providers. And so they are not incented for that information to get out. They believe it will reduce their competitiveness. So they treat the prices as intellectual property. On the provider side, providers fear they're not going to be rewarded for high quality, that the quality data won't be presented in a way that might justify their higher price. And so then people will just go to a lower cost provider, not understanding that they have higher quality. Of course, I'd like to show them that previous chart about cost and quality. And this is a hard thing for us, but especially in the Bay Area. So some provider contracts don't allow us to show pricing information. Or the insurance companies. If you go to some of the health plans' websites and search for prices, you won't see them. And so these anti-transparency providers put gag clauses into the contracts. And so unfortunately, there are a lot of providers in the Bay Area that we can't show all of the prices for them because of these things in the contracts, even though we're very confident that we know what the prices are. So there are a lot of challenges. So we've been slogging away in the electron mines for years on this stuff. And I'd say at least 80% of the time kind of preparing data, especially healthcare is particularly messy data. So that in the US, there are about 800,000 active practitioners and so, of medicine, so doctors for the most part, and then a few tens of thousands of facilities. And they perform many procedures, especially the facilities. And so to get claims for every payer, because the negotiations are independent with each of these insurance carriers, to get enough claims for that to predict exact prices is just not really possible. It's not realistic to do that. And so we won't be able to get claims for everything that we need. The data is often pretty complete, so procedure codes are really important to us. And for some of the other things we do, diagnosis codes are critical. But sometimes the insurance carriers just decide to leave them out, or they kind of dumb them down, and we just see X-ray, but we don't know what body part the X-ray is of. That shows up in the data. All kinds of strange coding rules. These claims adjudication systems, pretty mysterious beasts. I'm pretty sure most of them written in COBOL, 1970s. People who wrote them, long since gone. They're retired. They're in Florida. And so when we call and we ask questions about things like, why this? It's like, don't know. It's like, that's what the mainframe said. So it is kind of funny. So like, to some sense, like I said, we're reverse engineering these negotiated rates, but we're actually, I think more so, reverse engineering COBOL programs from the 1970s. But please trust me, working at Castlight is better than that. It's pretty exciting. Because we're doing it with machine learning. It's cool, so we're using cool stuff to do it. It's just messy under the covers. So I'm going to talk about two particular problems that we've solved with machine learning. There's a bunch of different ones. So one of them is that in some cases, we'll have an incomplete set of prices for procedures that we believe a provider performs. So a bit of context for that. So the first problem here is we have to figure out, well, what procedures does this provider perform? We don't get that. We don't get like a list of data provided to us that says, here's what this doctor does. But from the claims data, we can figure out a fair amount. So when we see a claim for a provider and a procedure, OK, they must do that. They've done it in the past. Also, our clinical team provides us with expert rules of like knowing the specialty of a provider, what procedures very likely that they will perform. But it turns out this isn't enough to kind of get really all the procedures providers perform. And then another piece of context is that, as I mentioned before, providers will negotiate in groups. So what we did is we initially used Bayesian synthesis, and we're trying to synthesize the connections of the procedures to the providers. And that worked pretty well for us, but we've had a lot of trouble kind of tuning true positive, false positive trade-offs with Bayesian synthesis. And it's just, for this particular problem, difficult to work with. So we've been using, very successfully over the last couple of months, generative algorithms to generate the rules for determining what procedures a provider does and getting much better results and much fewer false positives, while still a good set of true positives. And so then what we do, once we figure out the procedures that we want to price for a provider, we then cluster similar providers. And we call these clusters cartels. And then we can look across the cluster, and then we can share prices in the missing gaps. So we'll see matching prices all the way across in a small area. And then we can fill in the prices for the cartels, clusters. So the other situation that I want to talk about is office visits for providers with no claims. And so there are cases where we want to predict prices, but we just have no claims at all. Maybe it's for a particular payer, or just even across all payers for a provider that just doesn't show up very much. So some additional context here is in the same region for office visits, the variation in price is somewhat limited. Where from our point of view, 3 to 4x is limited, maybe not from other people's perspective. But then also, we'll have exact estimates, typically for other similar providers in that area from the cases where we do have claims data. For doctors that do office visits, there's usually a relatively small number of procedures we have to predict. And we talked to the users, and we decided that price ranges, even though it's not as good as an exact estimate, would be valuable. And because when you have that kind of variation, even with, you might have these price ranges fairly small, or fairly large, sorry, but in many cases they don't overlap at all because of this really wide variance. And so that actually works out pretty well. So we ended up using a little bit esoteric algorithm called quantile regression forests to predict these prices. And what we're predicting is percentiles, or quantiles, is what this technique does. And so we use that to predict the percentiles to use for the price ranges for these provider-procedure combinations. And then with some iteration work, we figure out a way to prune away most of the really wide ranges that actually aren't useful, where there's not, where the variance doesn't justify the range. All right, so then personalized recommendations. So another interesting area. So some of my teams built a product in 2015 that we rolled out at the very end of 2015 called Castlight Action. And this is a predictive analytics system that we use to make healthcare recommendations. And so we've launched this for over 30 employers. And every day we score, with our models, we score about 3 million people to evaluate whether to make new recommendations for them. And we're using claims data and demographic data and how people interact with our application are some of the main data inputs into these predictions. So it is a recommender system, but it's not kind of your typical collaborative filtering, as the people who like spinal fusion surgery also like. That's kind of not what we're really going for here, and might be interesting to know, but I don't think it's helpful to people. And so what we're actually, the type of recommender system we have is it's expert recommendations that we're trying to make for people that we've identified to have a similar condition or situation. And it's the identification part, that's where the data science comes in, mainly in this particular system. So the conditions, and we call these opportunity families, so like opportunities for us to make recommendations that are useful to people. These are the set that we're working with right now. And so then we break these down into segments. And then for a particular segment, we have very specific recommendations. So for back pain, maybe low back pain at risk of surgery. And so we're trying to identify people who have low back pain, and they might be considering having surgery based on what our model tells us. And as it turns out, imaging and surgery, clinical outcomes, well, imaging, mostly a waste of time, waste of your money for low back pain, and back surgery, clinical outcomes, relatively poor for low back pain. And so we want to tell people about other approaches. And so it's one thing to be able to very accurately identify people, and we feel like we're doing a pretty good job right now of that. But it's no good if we can't then do something with that, and something actionable. And so we thought about, well, what kinds of recommendations, and this was we were designing and building the product, what kind of recommendations can we make for people? So hopefully you saw from the price prediction that we can direct people to high-value providers. But in this case, we can, since we know their conditions fairly confidently, we can direct them very easily to providers that are very relevant to them and be helpful to them. And then we built up our educational content so we can then deliver useful information about those conditions to them. And then, and this is important for the employers, that we can then increase awareness about benefit programs. So rather than just hearing about them at open enrollment, when something changes in your life, maybe we see something in the claims, like you're recently diagnosed with diabetes or with low back pain, then we will make these recommendations to you and maybe telling you about programs that you may have you've forgotten about even exist, but you could benefit from and take advantage of. And so just a couple examples, and I'll just talk about the top one here. So like with low back pain, what we might do if the employer offers a second opinion program, we'd like them to talk to somebody besides a back surgeon, because back surgeons have kids to put through college. And it's like when you got a hammer, you recommend the use of the hammer. And urgent care, for a lot of, so the evidence-based treatment for low back pain can be done in urgent care centers for the most part, and in most cases, as opposed to ER. Much lower cost, much faster. And then we can provide information about self-care strategies that they can use. So this is just an example of content for people with hip or knee pain. And so we're getting really great engagement. So when you provide relevant, concise information to people, about conditions that they have and accurately target them. So really, really good engagement rate of like opening emails and clicking on the recommendations, viewing the recommendations, and taking the actions that we recommend to find out more about their conditions. And this is a huge part of, like the content team that we worked with is a huge part of the success of this application. The data science is really important, but it's part of a much bigger product, and it's very important to focus on that. So then finally, so the US healthcare system, when I started at Castlight about 5.5 years ago, about the only thing I knew is that my mom was a nurse. And I go to the doctor about every 5 years. So I don't know too much about the system, but I've learned there's an enormous opportunity there to improve the situation. And we're doing some interesting things at Castlight, and there's some incredible companies in the US doing some amazing things to try and improve the situation. We've had a lot of success using machine learning for these cases, but there's a lot of other interesting work going on at Castlight right now. So thank you very much.
Great, Robert, thank you so much. Got about 10 minutes for questions before we take a break. OK, we'll start right at the front here. Thank you. Chris.
Thanks, Howdy. I'm Chris. Great presentation.
Thank you.
So with the recommended, like pointing employees to benefits programs, wellness programs, or whatnot, it seems like maybe you're losing the access to the data that you had with all the medical stuff coded and coming out of the providers and that sort of thing. How are you tracking them once they don't get into the system that has these really noisy 80% of the time you got to fool around to figure out to get the data out of, and they go off and read something and say, oh, gosh, if I do this exercise, I'll feel better, and now you've lost their data stream.
So are you talking about people who read Dr. Oz? Or?
No. Just the recommendations that were sitting right up there.
Yeah.
Saying go do the, like pain management means exercise. It sucks and it hurts, but if you do it, it'll be better.
Yeah. Great.
And then they're gone. You're not getting that data trail anymore.
Got it. Yeah. Yes. So we do get ongoing claims, and so we will, as long as that person stays with that employer, we will be able to see kind of the course of their condition. And be able to tell, in some cases, we actually will be able to, so we will see that whether or not they go and get low-cost lab tests, whether they start going to urgent care. And we're seeing that already of some of the impact of the recommendations they make. So great question. And that's the main area we can tell because of the claims data. We can see the outcomes. Some of the stuff that is a little more opaque to us is like we try to connect them to these programs, but we can't always tell whether they join them. And sign up or not. And so we're definitely working on that to try and get that input. So, thanks.
Let's go to the gentleman right there in the blue shirt, and then we'll come across.
Thank you very much. This has been an interesting topic. It seems like there's a fine line when you're making expert recommendations because you're not a licensed medical doctor. And so how do you balance that of making recommendations and making sure you don't cross the line and making the wrong recommendation?
Right. Excellent question. So our clinical team partly makes sure we don't do that. So they know what are medical recommendations and where it crosses the line, and they ensure that our content doesn't do that. We also spend a lot of time with focus groups, and we do sensitivity testing. Turns out there are companies out there that you can contact and say, I'd like to try something and run something by people with diabetes. They're in this age range and a few things like that. And you pay them, and then you can send your content to them and get them to review it. And so we do that as well. And especially one of the very sensitive topics, but it's a really critical one, is behavioral health. And so anxiety, depression, substance abuse. So we spend a lot of time kind of tuning those messages to make sure that they weren't too pointed and too direct, and also didn't come across as we were telling somebody to do something, but more presenting potential opportunities that they might want to look into.
Okay. So we'll take the mic down here, the gentleman in the light gray shirt. Thank you.
So do you get data from HMOs like Kaiser? Because I don't think they generate, they internalize all the individual procedure costs. And I don't think they generate claims data to any external insurance companies.
Right. Yeah, we don't work with Kaiser right now. I personally am actually on Kaiser. and with Kaiser, because the physicians are on salary, with Kaiser, it doesn't really matter which one you go to. So with HMOs, what we do is not that relevant. And so it's with PPOs, high deductible plans, and things like that. That's where it makes sense to employers.
Okay. All right. Thank you. Let's take the question just in the row in front there. Yeah.
Are there tools in data science that you can't use because this is dealing with people's health? For example, A/B testing, right? So would you do A/B testing? And what are other things you can't do?
So around A/B testing is, I mean, any content that we would consider to put in front of anyone, we would to real users as opposed to the kind of the focus groups. Once we get past that, we feel pretty confident that it's suitable content to send out. And so we don't there aren't really as much concerns around A/B testing or anything. Kind of more the constraint is, I guess, around technology would be where we can have this data. So it can't leave the US. It's very difficult in a lot of cases to work with cloud providers. So we use a co-location at a data center. Data centers in the US as opposed to kind of AWS or Google Cloud. You can, it's just a little bit trickier to do that. And the employers that we work with, a lot of them are very, very conservative about it and don't want us to do that. So that's really more kind of the problems that we run into around HIPAA.
Okay, let's come back across to this side of the room. Yes, gentleman there, and then we'll take a question right there.
Hi, yeah, like a two-part question. So first of all, like what is the engagement rate or like click-through rate of these personalized recommendations that you're providing? And then sort of secondly, is in some way are you like perversely incenting people to actually consume health benefits that they might have otherwise not, and causing like short-term costs to like a self-insured company? So for example, like I probably wouldn't do like preventative colon cancer screening, but if I could go take like a low-cost fecal immunochemical test, maybe I do. Like, do you measure that sort of over time?
Yeah, good. So we're, depending on the opportunity, we get anywhere from 10 to 30%, 35% click-through rate. So very, very good. On typical marketing, you would see kind of maybe around 20%, 15% for that. So and some of the ones where it's like maybe a little bit lower around pregnancy, but behavioral health actually quite high. A lot of interest in that. So the engagement rate is quite good on those things. And on the second question of, so one of the categories was gaps in preventive care. And so we're identifying people who have gone probably too long, like myself, without having a preventive care visit. All that's typically these days is more than a year is typically recommended for that. It's not the annual physical exam anymore. And so we actually are encouraging more use, but more around preventive use and more around lower cost use. So for like the fit test that you can do every year, I mean, you get better clinical outcomes for that. And then for a colonoscopy every 10 years. And the cost for 10 of those is well below the typical cost of a colonoscopy. But it is an interesting conversation with our employer customers, this trade-off between, in the short term, we have to tell them, it's like, don't expect ROI, don't expect dollar for dollar on this kind of thing. And that's when working with big enterprises, when they buy things like this, they often, that's what they want. Well, actually, they want $5 for every dollar they pay back, and ROI. And so we actually talk about this as VOI, value on their investment. And we try to demonstrate the greater engagement of their employees, that's beneficial for them, and also the engagement that we drive with these other benefit programs, which they pay quite a bit for.
Okay, let's take a last question before we take a break. Yes.
Hi. I hope this doesn't sound cynical, but I was just wondering, is there any like conflict of interest when you're working for enterprise? Right, private enterprise. So the data, it all sounds like a win-win for the patients and the insurers, i.e. enterprise. But what if there's a conflict in the data? We always hear like 20 years later, the sugar lobby suppressed those research papers from Harvard that sugar was worse than, so there's always seems to be some conflict of interests. And what if the data showed that it would cost more for employers and the outcome for the patient would be better? It's always easy to say, oh, the patient needs to do more exercise, eat right, this and that. What if it said we need to pay more? How does that work with a company like Castlight and the people you work for?
Yeah, that's a very fair question. So one area where you could imagine like a conflict of interest is if we had a relationship with providers and that we might, say, prefer certain providers in the search results or rankings because of some kind of a relationship. So we very strictly have avoided that. Or another thing could be if we directed kind of incorrectly or inaccurately tried to direct patients and employees to lower cost healthcare where it matters more to the employer than to the patient. So a good example would be, say, a hip or knee replacement. So the cost you might see there, $15,000 to $75,000, that is going to blow out like anybody's out-of-pocket max. So for the employee, why would you shop? Why would you look around on cost? You have no reason to. You're going to pay the same amount. But the employer, it matters a lot. And so that could be, potential conflict for us that we have to consider of not trying to drive people too much to these, low-cost providers just so that it's benefiting the employer and not benefiting the employee. So it's definitely all things we try and keep in mind and try and avoid all of those conflicts.
Okay, great. Robert, thanks again for your time this morning.